caused by germline mutation is mismatch repair genes. It correlates with favorite immunotherapy response. Accurate clinical identification of this patient is crucial for improving outcomes. Genetic testing can help us evaluate patients' prognosis. Previous studies have shown that MSHI high is a favorable prognostic marker, while BRAF mutation indicates poor prognosis. The general prognostic hierarchy is as follows. In addition, a study published in 2019 demonstrated that ZZ patients with MED4 deletion have significantly reduced recurrence-free survival. Thus, MED4 deletion is also recognized as one of the markers of poor prognosis. The NCCN colon cancer guidelines note that ctDNA is being studied as a marker of evaluated recurrence risk in stage 1 to 3 colon cancer. Dynamic trial enrolled stage 2 colon cancer patients, evaluating if ctDNA-guided management could reduce adjuvant chemotherapy without raising recurrence risk. Experimental group patients underwent post-operative ctDNA testing at week 4 and 7. ctDNA-positive patients received chemotherapy, while negative ones were exempt. The primary endpoint was the 24-month RFS rate between two groups. The study results showed that ctDNA-guided group received less adjuvant chemotherapy than the standard group, with no significant difference in 2-year RFS rate. In the ctDNA-guided arm, positive ctDNA results at week 4 or week 7 were identified as poor prognostic factors. This finding suggests that positive post-operative ctDNA is also one of the markers of poor prognosis. 2 post-operative ctDNA tests enable nearly half of the patients to avoid adjuvant chemotherapy. This approach may truly distinguish high-risk from low-risk patients, sparing low-risk individuals from unnecessary chemotherapy. Next, I will share 2 cases to illustrate the application of NGS in clinical practice. Case 1, a 37-year-old male with ECOG 0. He was diagnosed with rectal cancer and liver metastasis in November 2019. He underwent radical resection of rectal cancer plus open liver tumor resection and RFA, stage 4 dMMR, KRAS, NRAS, BRAF, and PI3Ka wild type, germline MSH2 mutation, MSHI high, and TMB high. No family history of cancer was reported. The patient was identified with a likely pathogenic variant of MSH2, suggesting a high risk of Lynch syndrome. Based on the Keynote 016 clinical study, we selected pembrolizumab monotherapy. Unfortunately, the liver metastasis progressed significantly after 2 cycles. We reviewed